Welcome to the August 2018 session of our Patient Safety Webinar Series, co-hosted by the UNC-HSE Institute for Patient Safety and the NNLM South Central Region. Thank you so much for joining us today. We have two speakers with us this afternoon or this morning, depending on where you are. First off, we have Dr. Allan Frankel. Dr. Frankel is a physician who uses his 30 years of clinical experience, healthcare administration, and knowledge of patient safety and reliability science to help healthcare organizations and clinicians improve the reliability and safety of the care they deliver to patients. He is an anesthesiologist with pediatric and cardiac expertise who has worked in academic and community settings. From 2000 to 2007, he was the Patient Safety Officer for Partners Healthcare, the umbrella organization for many of Harvard's Boston hospitals. Since 2009, Dr. Frankel has been focused on improving the analysis and use of healthcare organizations' cultural survey data and risk quality data to support and hone improvement efforts in pursuit of operational excellence. Beginning of 2013, he has focused on developing an intuitive and easily instituted management system to foster the organizational culture necessary for operational excellence and high reliability. His group Safe and Reliable Care created LENS, a learning and engagement system now implemented in healthcare and non-healthcare organizations across the USA. Over 20 years, Dr. Frankel has co-chaired a host of collaboratives sponsored by the Institute for Healthcare Improvement, and also co-created and teaches in the IHI Patient Safety Executive Department program. That's our first speaker, very credentialed as we can hear, and our second speaker, Dr. Maleek Jamal, is just as experienced. He is a healthcare strategist and implementation leader who helps healthcare systems achieve the triple aim by building the system and site-level infrastructure, capacity, and cultural alignment across the care continuum to enable transformation. He began his career in regenerative medicine, earning his doctorate from the Genome Innovation Center at McGill University in Montreal, and went on to co-found a biotechnology company that patented and advanced a new therapy for diabetes. He then joined and went on to lead the healthcare practice of the Boston Consulting Group, where he partnered with boards, CEOs, and business unit leaders from Fortune 100 organizations. His project teams focused on business imperatives for growth and operational turnaround that required both integration and alignment of organizational resources and the development of new business units to disrupt markets. Since 2009, Maleek has advanced efforts to measure and improve culture of burnout across U.S. healthcare, delivering consulting and solutions to more than 1,300 hospitals. He has worked closely with executive and clinical leaders from organizations including Mayo Clinic, Kaiser Permanente, the University of California, Alliance Healthcare Services, and the Military Health System to develop and implement high reliability transformations that have created new clinical operation and financial value. So, enough for me. You want to hear from these gentlemen. I'll give the ball over to Dr. Jamal and let them get started. Good afternoon, Allan and Maleek.
Hey there, thank you.
Good afternoon, Sarah. It's a pleasure to be with everyone this afternoon, and thanks for making the time. Can everyone see my screen?
Yeah, two faces, Maleek.
Yeah, there we go.
Yeah, the rogue gallery. You've already started.
Fantastic. So the objectives for today are really, fourfold. One, we're here to share with you a framework for operational excellence and high reliability culture transformation. We're going to define what those things are, walk through a framework that's based on 2 decades of experience. The second thing that we're going to do is talk about the important aspects of culture that have now emerged in 2018, including burnout, engagement, and what we call change readiness. What are these topics? Why should you care about them? How do you measure them? The third thing that we're going to be doing is actually then looking at some really actionable ways in which you can actually begin to reduce burnout and engage your teams in improvement work that's visible, that's tangible, and that essentially drives change in your organizations. Lastly, have fun. We're here to have fun together. We're here to make you feel comfortable in asking questions, and certainly would love to make this as much of a conversation. So Sarah is also monitoring the chat If there's questions, comments, she'll be able to help triage those as well. So taking a step back, as we begin, it's very important for us to understand what are the forces at play today across healthcare. There's been an incredible change over the last, several years in particular. How have those changes impacted culture in our organizations and burnout especially? The tale of the tape remains true. More than 440,000 preventable deaths that we know of every year in the U.S. alone from medical error. There is an incredible triangulation around these data, whether there are large integrated health systems publishing very brave data on their performance using things like the IHI Global Trigger Tool, or from the Office of the Inspector General, the Institute of Medicine previously, lots of, triangulation around this number. When we look at preventable adverse events annually, that number is more than tenfold higher. It's about 4 million per year. And what we know based on the data, and this includes some work from Tejal Gandhi at Partners, that about a third of them are occurring in our emergency departments, and the bulk of them are actually occurring in medical offices. So the focus that we're seeing currently on the care continuum and advancing quality initiatives there are certainly well-founded. So lots of events going on annually. When we look at the breakdown of what's driving these errors, at 70% of the time, it's still communication and collaboration. It's multidisciplinary teams that might be geographically co-located or geographically fragmented, having fundamental issues with how they're communicating. The data remains, and this is Medicare and Medicaid data, a third of all hospital patients are harmed within 24 hours of their admission, and a fifth of all patients are actually readmitted within 30 days. So the size of the opportunity here, and as it directly relates to cultural topics of communication, collaboration, are profound. What's also profound and growing is the number of regulatory agencies that are affecting healthcare. The lists are growing exponentially, the rules are growing exponentially, and it's another thing for healthcare and healthcare administrators to be tracking. The other piece that actually, 2 years ago came in was ICD-10, and the number of code sets grew by 7-fold. So now if I'm a provider and I'm seeing somebody, as a primary care physician with a sprained ankle, I'm going from, documenting 5 codes in the past to 45. Angioplasty went from 1 code to over 1,000 codes. So the burden, so not only do we have, a better ability to measure harm and we see elevated numbers, but we're also adding burden to the providers as well through some of the additional changes in the ICD world. As somebody with a PhD in genomics, this has been really interesting to see. The age of genomics is now upon us, the age of precision medicine. The facts available per physician decision point from the world of genomics has actually increased, 100-fold. In 1990, primarily in the world of oncology, if you had an oncogene mutation or a certain type of deletion that made it easier for you or more amenable to be treated by a certain therapy, that's what was used. We've headed into a world where there's more than 1,000 pieces of data. So again, more complex, more chronic issues to manage. Diagnosable disorders using genetic testing have also increased commensurately. So the scope of practice and what's out there, if I'm a provider, has just changed. So the volume of information is ballooning, and the challenges are also ballooning. Now this has had a direct correlation with physician burnout. So what you're seeing here are a variety of specialties, starting at the top with emergency medicine. The mean is actually the darker blue bar, but in general, you're looking at more than 40% burnout rates across physicians, across specialties. And Maslach, who essentially remains kind of the gold standard, who created the Maslach burnout inventory, which really remains the gold standard for measuring burnout, defined, over 30 years ago, burnout as a syndrome that involves emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment that occurs when in the helping professions. This definition, there are many definitions, but this really has become the gold standard and the gold standard way in which to measure burnout. So the correlations to burnout are enormous. Burnout itself continues to increase close to 7 to 10% per year across all healthcare providers. The other interesting data here is when you look at the percent of physicians that are actually, the percent of physicians that believe that after work there's enough time for personal life or family life, that's a horrible statistic of around 50% at the mean. So clearly, in addition to patients being at risk because of how healthcare is designed from a systems process, it's very clear that our providers are also at risk and our personnel. When we look at taking a step back and all over healthcare, what we see that's emerged that's different than it was 10 years ago, and it's certainly different than it was 20 years ago when we first began measuring culture using the Safety Attitudes Questionnaire or the AHRQ survey. What is now true is that the major epidemic in healthcare is burnout and the ability to speak up, psychological safety. You have more than 50% of staff across U.S. hospitals not feeling comfortable speaking up about an error. Very different than the Southwest Airlines mantra where if you see something, you say something. Very different. 55% feel inadequate about handoffs and transitions. This is a staff member saying, I'm not comfortable with the quality of a handoff on a patient that we had to the next level of care. Absolutely profound data, and it's there not just in the SCORE benchmark database, the SCORE integrated survey, but also in the AHRQ benchmark. And last but not least, and most importantly, the burnout rate in U.S. healthcare is now more than 50%. One of the very powerful factoids within that is that a quarter of all new nurses leave within a year of practice. So we are in a place where the pressures on healthcare have increased so much and that the sustainability of the system is at risk. If you read the most recent PricewaterhouseCoopers report on human capital across the U.S., it talks about healthcare having a 3 times higher rate of turnover than any other industry in the U.S., number one, and number two, how 18% of the U.S. GDP is spent on healthcare, but within that 18%, 5% is spent on non-voluntary or voluntary turnover, the direct cost associated with people leaving our organizations. So, these are all kind of cultural facets. Now, on top of this is the financial pressure. The direct cost of errors as of a few years ago was $17 billion out of a total healthcare spend of about $3 trillion in the U.S. And within the MIPS macro world as well as value-based purchasing, today, over $10 billion of payments, just Medicare payments alone, are being withheld. And these are across safety and outcomes, so mortality, bloodstream infections, UTIs, surgical safety, surgical site infections, patient experience, efficiency, as well as clinical process. So there's absolutely pressure that's being placed on organizations, and that financial pressure it comes at a time where hospitals already have extremely low operating margins. It's a 2 or 3% net operating margin business. Today, if you look at the 5,600 hospitals in the U.S., 25% are not making any money. They're not profitable. Another 61%, about 2/3 of all hospitals in the U.S. have declining margins, and the rest of the 20% are expecting a decline margin drop. So as budgets contract, it becomes very important to design efficient systems of patient safety and reliability that not only deliver safety and safety for patients and staff, but also are able to kind of demonstrate, cost savings and reductions. So that becomes another element of pressure on the system and on providers as we now think about, well, given this context, how do we actually achieve sustainably achieve safe and reliable care? So I'm actually going to pass it over to Allan, who's going to walk us through a framework to be able to look at this. So, Allan, I'm just sending you the presentation privileges, and there you go.
All right. Let me share my application. We'll do this one more time as part of this talk. So, Maleek, I have to tell you, I looked at your slides and I went through them with you, but I didn't realize just how challenging a job you were gonna set. Because when you listen to all of it, it's got it's not a bleak quality to it, but boy, have we ever, taken ourselves into an intensely complex environment with factors that are just so huge and at times seem so overwhelming. And I'm presuming that for many of you on the call, like Maleek and me, we are going into organizations with the request to, how do we move from the current level to the next level of care in which we can achieve our vision and our goals of sustainable, safe, and reliable care. And then you look at all these challenges and you go, well, good grief, how is that possible? And the interesting piece is, I'm just reflecting on it before I kind of get into some of the concepts and details, is that Maleek and I and my group do have the privilege of walking into your organizations, many of them, and finding these bright spots that are just stunningly, and they're so attractive. You walk in and you go, yes, as a patient, I could get care, and I would send a family member. And over the decades, we've been asking ourselves, what characterizes those areas, what makes them special? And I'd like to say that I've walked into an entire organization that looks like that, but the truth is that isn't the case. I think this is very hard to achieve holistically in organizations, but that's the goal. I would actually say that if you could get a tipping point number of your work setting, clinical and non-clinical, to have that kind of quality where you walk in and you go, oh, I know this is going to be okay, that then becomes the ball that allows you to kind of roll the process through your organization and tackle these many challenges that Maleek has described, and there aren't all of them. There are others also. So one of the pieces we also know, and this is from a lovely work that was done by McKinsey, is that the effort I just described, the request of us to come in and run programs, those kinds of programs do not have a huge success rate. Truth is, 30% success rate, given what Maleek described, is actually pretty reasonable when you put it together, but it is not adequate. My guess is it wouldn't be adequate for any of you, and it's not adequate for us. We'd like 100%. Can we get 90, 80, 70%? Can we get enough organizations and units to change in the direction that kind of moves them towards joy in work for employees and a high-quality, sustainably reliable care? Can we get them to a tipping point that allows them to then move forward? And the answer is, I think, yes, even though as we look at the activity over the last couple of decades with our culture surveys, we haven't seen huge changes in the overall scores. And a piece of that is that, well, I think we have all done really good work. We have also been doing good work in a climate that's increasingly more complex and more challenging. And how the two balance each other out is an interesting question, but the overall perspective by people working in our industry has not changed. So, where's the end in mind? The cultures that convene and improve. Now, here is one example. Mayo Clinic is a remarkable organization amongst all of our organizations, and it's, it's remarkable even amongst the remarkable ones. And they have indeed run programs, a commitment to safety and team engagement program, that have had pretty impressive results, as you see down the right-hand side. We were privileged to come in and work with them on some of their efforts. So we were able to shape some of the initial activity, and that's a bit of what I want to speak to, not specifically Mayo, but these are programs that we have run, through the Institute for Healthcare Improvement, with IHI through the country of Scotland, and in a number of programs in England, with my group in England, with maternity a few years ago, and then across major healthcare systems and smaller healthcare systems across the U.S. As a result of all of that work, my group and folks from the Institute for Healthcare Improvement, through the Patient Safety Officer Training Program, began to characterize the necessary ingredients to see a local work setting excel. Now, what do I mean by a local work setting? I'm talking about a culturally distinct entity that tends to have names that you are all familiar with because they go by names of departments: radiology, pre-anesthesia testing, central sterilization, the booking office, Dr. Jones, surgical practice, the medical office, office clinic. And we think of those as departments. I think of them as work settings, as places where different disciplines convene together, where individuals in those disciplines identify themselves as belonging to those units, where people develop relationships with each other. And it even extends into places like home care, where just last week I was talking to a nurse manager who has 18 nurses and occupational and physical therapists, and they spread, across 50 miles in all directions to take care of patients. But if you ask them who they are and what they do, they'll tell you that they're home care and that they belong to this particular department within home care, geographically dispersed, but perceive themselves as belonging to a work setting. So if that's true, then your organizations, and the truth, every organization we've gone into, is made up of serial work settings that we think of in essence as service lines: surgery, medicine, oncology, pediatrics, and so forth, and that those series of work settings as service lines come together to be acute care institutions or integrated delivery systems. And so each work setting has to be profoundly effective, and the covering organization over it has to apply the appropriate resources and standards and other components to support each work setting to be internally outstanding and to be able to engage in interface conversations with other work settings to smooth the process of care as patients flow through. So from the surgeon seeing a patient, making a diagnosis, to booking the case, to coming to pre-anesthesia testing, to then pre-op, intra-op, post-op, onto the surgical floor, to rehab, and then back home to be taken care of by home care, your surgical service line is a series of work settings that need to be internally strong and engage with each other across the interfaces. And each of those work settings has a set of common characteristics. They have organ systems that are similar across them in the same way that organs are similar in a human being. And the analogy works, and those of you who have, I saw some familiar names who've heard me talk about this before, the organ analogy works because these living, breathing entities, the operating room, the radiology department, the medical floor, these living, breathing entities have organs, and all the organs have to be healthy. You don't get to choose that some are and some aren't, if indeed you want a fully robust patient. So what are the organ systems and what are the characteristics of them? Well, the way I think about it and the way we've kind of developed this and then written it in our white paper with IHI is that we think of two main ones. There's this thing we call culture, which I'm going to define in much more detail, and then this other entity that we call learning, which is a slight misnomer. It's really improvement readiness. And both of them are managed by the strings that get pulled that determine their shape are managed by the leadership at the work setting level and then more distantly at the senior level within the organization. And leaders have specific qualities and characteristics. And the reason why we put this up here in a slightly different color is that our experience has been that as we go into organizations worldwide, there's 1 in 10 or 1 in 20 of this middle management group, nurse, doc, administrator, as the case may be, who have the requisite skills to run these work settings. And 80% of this middle management group tend to be highly skilled, invested, passionate individuals who are socially capable but don't and have not been taught the requisite skills. And there's another 10% who we can talk about but won't go into detail who shouldn't be in the positions that they're in, unfortunately. And there's a lot of reasons why they're there, and none of them all that healthy. So what do you want of this middle management? You want them to realize that they are running improvement readiness systems, these things we call learning systems, and that their primary responsibility is for this thing we call learning, and that to achieve learning, to gain the insights necessary to learn and improve, they have to create an environment of respect and psychological safety. So the title of chair, chief, manager, director means you are guardian of learning, respect, and psychological safety. You own that responsibility. Psychological safety is well known from Amy Edmondson's work, so the attribution is absolutely clear here. I can ask questions without looking stupid. I can ask for feedback without looking incompetent. I can be appropriately critical without seeming negative, and I can suggest innovations without looking disruptive. And I can do that not simply at the clinical bedside when I'm worried about a patient, but I can do that in the office meeting in the huddle where the hierarchy sometimes takes a different quality to them, and these things are harder to do in that environment because it isn't necessarily around a specific patient. But leaders have to guard the ability for individuals to do this in their environment if indeed they want a learning system that's robust. Well, with leadership and psychological safety in place, the organization as a whole has to account for how people get treated when things go wrong, job culture, and it also has to account for behavioral expectations or professionalism. What is expected of us when we interact with each other, it really translates into respect. But those have to be characterized by the organization as a whole, and then it allows the middle management to make that manifest within each of the work settings. It's a little more difficult if the management has to do it at the local level. It's doable, but it's much tougher. These three components are made manifest in the team activities that occur within each work setting. You know, we talk about them as huddles and briefings and pauses and timeouts and so forth. But what people actually do during those periods of time is all over the map and does not, most of the time, encompass the characteristics that I'm describing to you here effectively enough. Operational huddles are easy. This many patients, this many staff, this equipment. But complete huddles are, well, how are we going to speak to each other? Will we know the plan of care? Is communication going to work, and did it work yesterday? There are conversations within huddles and in the debriefing, the reflecting back of the activity, that requires skill by managers in order to be robust and is essential. So we've been teaching teamwork now for a couple of decades, you know, and now honed into this team steps, a set of trainings. But that needs to be linked to the accountability, psych safety, and leadership components and made manifest within each work setting. Those four then you add to the ability to negotiate differences and resolve conflict, and you get the cultural base on which, clearly we have an emergency coming in. We have the cultural base on which the learning system then becomes manifest. Now, what's a learning system? Learning systems are improvement-capable entities. We're not talking about education, we're not talking about research as learning, we're talking about improvement-capable. And improvement-capable means We can identify clinical, cultural, and operational defects. That's what continuous learning entails. Clinical, operational, and cultural defects. So I didn't titrate the medication in the way I would have liked to. The patient's blood pressure was too high, too low, clinical. I didn't have the blood pressure cuff in the room that was supposed to be in, and it didn't work, operational defect. We didn't communicate effectively between the two disciplines or during the huddle, so I didn't know the plan of care, a cultural defect. Those defects have to be identified in real time on a day-to-day basis, presuming that the cultural milieu is sound, then you're able to do that. You then have to have the capacity to apply improvement and measurement to that effort, Lean, Six Sigma, the model for improvement. You have to make that process transparent and visible so that people, when they speak up, see action occur, which then creates a positive loop that says, oh, my voice is heard, and all of this is in service of reliable care for patients and their families. So when we look at the component pieces of the puzzle, what we see is being able to regularly collect these clinical, cultural, and operational defects and successes, use standard improvement tools, apply best evidence, use whiteboards, learning boards to openly share information in pursuit of this overarching goal that is the only means by which we are going to be able to address the many challenges that Maleek identified early on. So to summarize, leaders are guardians of learning, respect, and psychological safety. In a culturally leaders team, psychological safety with clarified accountabilities and the ability to collaboratively navigate the differences. And in a learning system, defects and ideas are measured and improved in pursuit of reliability, and the process is always transparent. And the images of the various organs in a human being at the bottom are a reminder that you don't get to pick which one of these are strong and which ones aren't in each work setting. It's the job of senior organizational leaders and the middle management to create strength in every one of these in every work setting, or the system is not going to be able to achieve the kind of results that we are all interested in doing. What's the ideal? Self-reflecting, improvement-capable work environments is the goal for every person who becomes a chair, chief, manager, director. We know that there's a cultural maturity model that as organizations become more sophisticated and move up the model, they become increasingly more capable. They stop looking in the rearview mirror at bad events. They begin applying systematic processes as in, team steps would be one of them, management methodologies, improvement methodologies, and all of those are useful, but none of them land on fertile ground until the culture is healthy, at which point in time you get a tipping point and you shoot into these proactive and generative environments. And, our experience has been over the years that you don't watch groups simply kind of meander up this process. That all of the components get aligned, and then there's a change, and you can feel it, and you can sense it when you come in to these departments that have started to move up the process. And in relation to some of the major issues that Maleek referenced earlier on around burnout and resilience, that as the units become more capable, the levels of resilience in individuals go up and the levels of burnout go down. So if you want means to deal with the burnout issues that exist and are getting worse in healthcare today, you have to create voice with action at the work setting levels that make people feel engaged and that they have value in order to address some of the fundamental problems now that seem to be so hard to achieve. With that, let me hand this back over to Maleek and let him move us forward a little bit further.
Great.
Let me just give you the ball move.
Sure, and I'm actually having some, well, Allan, do you want to just continue running? It looks like I'm having some difficulties grabbing the...
Yeah, I'm happy to do it. Do you want to give me back the ball, Maleek? All right, so one more example of technical problems in healthcare. that are extraordinarily frustrating. Yeah, Sarah, Annette, you can give me back the ball. Great. Okay.
Great. So, you know, the piece around the tipping point also, if you look at some of the data, really links back to psychological safety, the ability to have a voice. Organizations really continue to struggle with how to measure culture effectively. You know, and there's been a variety of different approaches over the year, each of which have kind of matured in their own time. Allan, I'm actually having a little bit of difficulty here advancing these slides.
Well, I can advance them for you.
Okay. You know, give me 1 second here. So, Allan, do you actually want to kind of run through some of these while I catch up a little bit? I think my computer's actually just crashed, is what it is. So.
Sure.
Apologies.
Sure. Yeah. All right. Well, so the measurement of culture has actually been an interesting one, and part of the challenges that we ran into is that as we looked at the culture surveys that we've been using, so, you know, the history is the Safety Attitudes Questionnaire came in '94. 10 years later, the Agency for Health Research and Quality Survey on Patient Safety came in 2004. And those surveys were created by really bright, capable people. You know, Brian Sexton, who's now Duke. At the time the SAQ came in, he was working with Bob Helmreich, who has since passed away down at the University of Texas. And both Jim Battles, who worked very hard at AHRQ to bring in the survey on patient safety, and Brian created, I think, excellent instruments for evaluation of culture, but challenged to some extent in translating them into action. And, you know, here we have one example where, you know, looking at catheter-associated infections, we couldn't find a relationship between the HCAHPS survey and the change in catheter-associated infections. So I actually went to Brian back in 2011 or so and said to Brian, you know, we're running these programs in large organizations in the U.S. I'm using the standardized surveys, Safety Attitudes Questionnaire, the HCAHPS survey. I know that there are changes that are happening in the work setting, but I'm not seeing those changes manifest in pre-post surveys that we're running in ways that give me confidence that we're accurately or effectively measuring. You know, and I'm not sure why, but I'm not satisfied with the current state. Some of it has to do with the fact that if you think of work settings as these self-reflecting, improvement-capable environments, then surveys need to evaluate self-reflecting, improvement-capable components. So we sat down and created and modified some of the instruments. Another component of this was we have got HR folks who have been running employee satisfaction and employee engagement surveys for decades. Along comes the patient safety movement in the early 90s and begins surveying in parallel, and not saying anything that those of you in the clinical environment don't know, but the surveys overlap, they're redundant, people get tired of taking them, and so let's merge them together. Ideally still giving safety and quality in HR the specific lenses they need, but also looking at the component pieces that are important in 2018. So we've been running SCORE across now 500,000 respondents, actually more at this point. And the domains are meaningful because they match what we think of in the framework, and I'll actually add the framework that I just showed you and the domains within SCORE relate to one another. You can't evaluate culture surveys if you don't have a framework in mind. So learning environment and local leadership are two legs of the, or two sides of the improvement of the improvement-capable environment. Do we pause and reflect? Do we gain ideas of use in understanding our defects? Do we act on them? Does local leadership help to make that happen? Teamwork and safety domains are historical domains. We left them because so many organizations use them, but the teamwork domain is multifactorial. Ours includes communication in work settings, across work settings. It includes coordination of disciplines, and it includes aspects of psychological safety and the ability to manage disagreements between people. That is bigger than teamwork. It has multiple components. If you want to move that number, you actually have to do different activities. Safety and teamwork overlap closely. Same work, the safety of the bellwether is I would feel safe treating patients. On the right-hand side, just to mention it, are the engagement domains. I can grow, I can advance, I can participate in decision-making. Those overlap with the cultural domains, but within advancement is I get paid a living wage, I can grow through training and so forth. And then the classic desires of HR are people thinking about leaving, are they uncertain about their positions? And then lastly, the grouping that has turned out to be fascinating is burnout. How emotionally exhausted, frustrated, cynical, sense of depersonalization and inadequacy do you see in the people around you? To what degree do you feel that way personally? And how is workload strain and work-life balance related to those two topics? And then two others which we've recently added, so we don't have, I haven't put the validity scores in here, but this concept of emotional thriving, that I come to work and it makes me feel better, or I deal with a difficult problem and I recover quickly, are two more lenses into the psychological health of personnel that can be leveraged by organizations to move activity forward. So we are now measuring all of these in an integrated instrument and gaining spectacular insights as a result. Let me pause because, Maleek, I can keep on going. How are you doing?
Sure, yeah, good. And just to continue from what Allan was saying, you know, as you folks take a step back and say, you know, how are we going to assess our culture in a way that's diagnostic, that's actionable, and that actually links back to outcomes? What we would encourage is to go and look for and find instruments that enable you to play offense, so that 3 months from now, the correlations are so high with things like turnover or burnout or medication errors or adverse event reporting or, you know, malpractice claims as an example, and really begin to pick the instruments that you're using based on some of these pieces. If you're going to go through the effort of doing a survey and assessing your culture, make sure the information that you're getting out of it is actually usable. Next slide, Allan. And show you some examples of just how usable some of the information can be. What you're looking at in front of you are real data from a 13-hospital system. The height of each of the vertical bars is the percent of individuals that agree or agree strongly on a 5-point Likert scale that in aggregate items within the teamwork domain. So this is from the SCORE survey as an example, you know, communication and those types of things. So a couple of observations that you see. When the scores are low, and let's say 60%, you know, below 60%, we've indicated those in red, we see tremendous correlation with falls, stage 3 pressure ulcers, and CLABSIs. When you cross that majority percent positive and above 60%, it's a very different culture. It's a very different operating environment, even at the hospital level. And we see significantly better safety profiles going on there. So now you're able to, if you're a system, you're able to look across the organization and say, what are the broad themes that I'm seeing? And what are the broad themes that I'm seeing, and where are there specific spiking points? If we double click into this and go to the next slide, the same relationship holds true at the unit level. And so simply to say where you really want to be at the sweet spot is getting really high response rate data across your organization and within each unit, and being able to show some of these correlations, which has been a very powerful way in which to engage leaders and clinicians in the important conversation of culture and improvement. Let's keep going, Allan.
Yeah. I'll just mention that this is a hospital system on the West Coast looking at operating rooms and looking at perceptions of psychological safety on the left, and then the months between wrong site surgeries underneath. The higher the scores on psych safety, the greater the time between reportable serious adverse events in those operating rooms. So the measurement of culture isn't soft and fluffy anymore. It's become hard-edged and can be, significantly influenced by organizations by improving perceptions and attitudes. You can get substantial change in clinical process and outcome. I want to spend a little time talking about burnout and resilience just to help define those as the resilience domains become more important as we evaluate them. So burnout, the first stage in burnout is emotional exhaustion. That's what we've been measuring using aspects of the MASLC inventory. I feel fatigued, I feel frustrated, I'm working too hard. By comparison, the resilience items, looking at this from a positive perspective, are emotional thriving and recovery. In emotional thriving, we're asking questions like, I have a chance to use my strengths every day at work. I feel like I am thriving, making a meaningful difference. I look forward to coming to my job. And then in the recovery component of resilience, I bounce back quickly after difficulties. I can adapt to events in my life that I cannot influence. My mood reliably recovers. I can regain a positive outlook despite what happens. And while these three are related to each other, the burnout and exhaustion, the thriving and the recovery, they have subtle differences that are impacted by different actions that get taken within organizations. By the way, these resilience domains are turning out to be, enormously powerful. The thriving ones are related to BMI, for example, lower BMI, higher scores. They're linked to the whole positive psychology movement. Gratitude is a huge piece of helping people thrive. So in the positive psychology world, coming up with tools that help you think about being grateful or think about being awed by, spectacular events, much of which Brian Sexton has available through the Duke Safety Center, can help around the positive psychology work. Same on the recovery side, where you can look at what are the things that help you, to most effectively be able to recover. And we won't deal more with this, but it certainly is a component that needs to be brought to bear by middle managers in each of the work settings. And this is just one example of Brian and Carrie Adair's work out of Duke, which is just fantastic. And you can, the bit.ly/grad tool is one of the ways you can go and look for that. The way I want to look at burnout and resilience is to just look for a moment at Schoenfeld and Steve Swenson's article in which they assess what are the things that you need to do to help improve resilience and decrease burnout. One, acknowledge the problem, which the positive psychology work would do. So can local leaders talk about how difficult things are in a huddle, and that everyone should go and do the gratitude tool or the 3 good things kind of tool. Harness the power of leadership, targeted work unit interventions, cultivating community at work, using rewards, aligning values, promoting flexibility. All of these require a self-reflecting, improvement-capable environment. So self-reflection and improvement capacity, the framework that I articulated early on, is not simply in service of increased clinical activity and operational excellence. It is in service of fundamentally fixing the cultural milieu within the work settings to then be able to target these specific components to improve perceptions of resilience and decrease levels of burnout, to then have an engaged population of providers and employees who will then work with your organization to drive it to operational excellence. That's the challenge in 2018. there are specific activities that can lead you down that path. This is data from 17,000 respondents in 29 hospitals in Michigan. 2 questions. Do you participate in a rounding process with senior leadership? Do you get feedback? The groupings, blue, red, green, are scores in the various domains of culture: learning, local leadership, teamwork, safety, the burnout domains, work-life balance. Blue is the average response of the 17,000 people. 10,000 people said, yes, I engage with leadership. And of those 10,000, 5,000 said, I get feedback. If you look at the 5,000 who did and the 5,000 who didn't get feedback, look at the difference in their perceptions across the entire cultural landscape. Huge changes in perceptions of learning, leadership, teamwork, improvements in burnout and personal burnout. So there are specific activities, and then the question is, what do leaders do when they do a rounding process? Do they know how to round? What's the conversation you have? How do you key into the component pieces within the unit to help you understand as a leader what to discuss to create the kind of engagement that then leads to, and resilience that then leads to engagement and capacity to be self-reflecting and improvement capable. These are the things we haven't characterized or taught people effectively within our organizations. There's a thought experiment that I'll quickly describe as the hour gets late. 2004 was Pronavost's study looking at central line infections. Those are, on the left, you see all of the ICUs in the state of Michigan and their bloodstream infection rates in a study where they were given a checklist for putting in central lines with the goal to decrease bloodstream infections from central lines. How effectively were they able to do that? And the answer is, if your teamwork scores were high on the cohort on the right, 44% were able to have no bloodstream infections over the next year versus 31% versus 21%. So the bottom line is that teamwork questions, the responses to teamwork, were predictive of being able to put in a process that led to a better outcome or decreased adverse events. If you look at the right in terms of what leaders do when they round, they improve perceptions of teamwork, which is the third grouping from the left, and would have driven the majority of the ICUs into the right-hand column and made them more capable when they went to put the checklist in for the central lines. So there are specific activities that can promote effective care in our clinical environments. This is an image of hundreds of whiteboards that Maleek and I and my group have been taking pictures of for the last 2 decades. They're all over the map in terms of what they do, what they show, and how effective they are. And quite candidly, they are all mediocre. There's a delay in the data goes up, there's limited engagement, people walk by them, there's scheduling challenges, the analytics are variable. All the ones we look at are just, including the lean boards, which get you some of what you want. We have not gotten where we need to in 2018 to run our work settings with visual management effectively. And that, I think, is where we are heading. We need to take the framework and make it visible in the analog boards so that you can actually see when staff have voice, managers can manage better, improvement is visible, and leaders and physicians are connected through, I think, digital learning boards, and that's what we are currently employing and experimenting, repeatedly over the last 4 years as a mechanism to improve how teams come together and leaders come together in work settings. So in summary, you have to have a framework when you come in and look at these work settings. The framework is now known to us. You don't get to choose which components of the framework are healthy and which aren't. You need all of them healthy. And if you have senior leadership and middle management aligned around a framework, it is feasible to begin to tackle the issues that Maleek articulated early in our talk in ways that can drive care much more effectively. We are indeed doing that in the interventions we're running with groups, so we know it's feasible, although we certainly have our failures too. Let me stop there, and hopefully I'm an anesthesiologist. I haven't put everyone to sleep, but we have a couple minutes for a couple questions, if folks would like to take them, and happy to engage.
Thank you so much. What a wonderful presentation. We do have a few more minutes for questions. If anyone does have a question, if you would please enter that into the chat box. We'll accept questions for a few more minutes before we wrap up for today's session. I guess I'll start off with one question for both of you. Do you have recommendations for those who might not necessarily be directly involved with clinical care? Are there ways for those of us who might be health information professionals or other support-related professions that we could be helping with this process?
Well, interesting question. I mean, I've got two answers. One is that the same set of attributes are true in non-clinical work settings as work settings. So, you know, if you're asking, as a matter of fact, we are running an intervention right now with the informatics department in a small community hospital, and what we're doing with them is the same as what we're doing with the clinicians in the emergency room and in their operating suites. So one answer to your question, Susan, is that the dynamics around culture are the same whether it's a clinical setting or a non-clinical work setting. The other answer I'd give to you is that I think of the non-clinical areas, quality, safety, risk, informatics, organizational development, systems engineering, all of those are essentially resource personnel to ensure that the clinical work settings achieve the framework components that we've described. So if you're wondering what your job is in those areas, that's your job. And linking into that activity within the organization, in organizations, is essential for the process I've described to be successful. We can't do what we do in organizations if we don't bring those groups to the table and if they're not willing to play with us.
Wonderful. Thank you so much. Well, it looks like we don't have a lot of questions coming in the chat box. Please feel free to pass those along to us or to contact Maleek or Allan with those questions. Again, thank you both so much for a wonderful presentation. I'm going to go ahead and end the recording, and then we'll move to our demographic poll. So everyone stay tuned for a few more moments.